Yeah, thank you. So this is an exciting trial. This is one of the first to look at chemoablation using a novel sort of delivery mechanism with this reverse gel formulation containing mitomycin. So what's interesting in this trial is that patients had not undergone prior TURBT. This is a chemoablation trial. And so patients with intermediate risk disease defined by the IBCG, so patients with recurrent low-grade tumors, any tumor greater than 3 centimeters or multifocal tumors were included in this trial. And so biopsy obviously was required to assure that the patients truly did have low-grade disease. And then they were offered the 6 weekly installations of the UGN mitomycin. So the results here are very impressive. 79% of the patients, almost 80% of the patients have had a complete response by 3 months. This is chemoablation, so it's really excellent response rates there. And most of these responses were durable. 80% of those patients who responded were still continuing to respond by 1 year. So I think the most promising sort of aspect of this would be the chance to have the tumor be ablated without having to go to the operating room. I think that's the most challenging part for some of the older patients, the ones who are on anticoagulation. So we're pretty excited to see these results and some other trials in this space as well. Yeah, especially, I mean, TURBT is always successful in our minds, meaning, we go in there with the intent to remove all the tumors. It's very frustrating for both the providers as well as for patients when you look in there again 3 months, 6 months later, and you have recurrent tumors. And so this, I think, really will impact those patients who've had multiple recurrent tumors and are tired of going to the operating room with the associated, side effects associated with that, from the anesthesia to intubation to having a catheter, postoperatively having chemotherapy placed each time. So I think that this is great to have an additional option for these patients, and I think it will be very well adopted both by practitioners and by patients. The patients don't like to go to the operating room multiple times, and seeing that their tumors are recurring all the time, they sort of want something novel. So again, great to add this to the armamentarium of the treatment options available for patients. Yeah, I think, as with any new treatment, there are going to be some challenges. One of them is coming in weekly for 6 weeks to get this treatment. But most of the patients are used to that. They've received either prior intravesical therapies, which are usually once a week for 6 weeks, or they have previously had multiple other visits for cystoscopies and things like that, so that the cystoscopy schedule is exactly how it is in standard of care practice. So I don't think that part is really much of a challenge for the patients. There are some patients, I think, who just don't like the concept of leaving a tumor behind and kind of putting a medicine in there and seeing what happens. Part of the other challenge is making sure that the tumors are not high-grade tumors. We are biopsying them. We're pretty sure these are low-grade, but a TURBT always offers the best sort of histological, pathological confirmation of the disease. Having said that, low-grade tumors have a fairly low chance, especially the recurrent ones have a low probability of progressing to high-grade. It's in the probably 5 to 10% range. So we're fairly comfortable treating these. We're already doing it in the office. There are other ablative therapies like lasers coming on, hopefully in the next few years, where we can do these office-based procedures. So I think honestly, there aren't going to be too many challenges in delivering this type of therapy for the patients in the near future. I think most of the patients, again, want to avoid the operating room if they can. Yeah, I think certainly adds to our armamentarium, right? I think this will, these are, yeah, absolutely. They met their primary endpoints so far. We've had excellent results with 80%. And again, the median duration of response has not even been met yet. This is an ongoing study. I think this does definitely shift our mentality into trying ablative therapies for patients with intermediate risk disease rather than taken to the operating room multiple times. And so, yeah, I think this may shift our mentality on how we treat these in the future. Again, there are other future therapies coming that have similar sort of concepts. And I think so, yeah, in the future, we're going to be doing much more in the office rather than in the operating room for this particular type of risk disease, or the low risk and the intermediate risk disease. Yeah, I think it's availability, really. We've seen with some of the new formulations of drugs coming on, reimbursement issues and availability of the drug to the practitioners are probably the biggest challenge, rather than the administration itself, where all urology practices managing bladder cancer are very accustomed to the various treatments, intravesical treatments. So that's not really the challenge, I think. What I hear from community urologists is I don't have it available, we can't afford it, the reimbursement issues and things like that. So the easier I think that you make that aspect of treatment, the more widely adopted it will be. Again, the 6-weekly installations is something patients are used to. Obviously, the less number of visits, the better, but I think they're more than willing to go through that than have an OR procedure each time for their recurrent tumors. Also, in the future, I think we should also be looking at ongoing treatments. There are patients who we really don't want to take to the operating room or can't take to the operating room, and they may not have a complete response. This is a clinical trial with the primary objective of being complete response. But there are patients we are currently managing with the aqueous mitomycin or gemcitabine that we just want control of the disease, control hematuria. And so I think this will actually expand the population, where we're trying to just control, multiple tumors and prevent the bleeding and other associated effects of having untreated tumor in the bladder. So we're excited to have soon multiple different options available for these patients.